Bismillahirrahmanirrahim. In the name of Allah, the most gracious, the most merciful. Quote of the day: the secret of change is to focus all of your energy not on fighting the old but on building the new. Assalamu alaikum everyone. I'm Dr. Mahnoor Khan, PGR in Department of Community Medicine in King Edward Medical University. I'm going to present on the topic of family planning program under the kind supervision of my worthy professor, Dr. Saira Afzal. By the end of session, participants will be able to define family planning and related terms, briefly describe how family planning contribute to Millennium Developmental Goals, describe the evolution, family planning, intervention from 1947, illustrate vital trends, discuss the role of funding agencies, public sectors and private sectors, sensitize the unmet need of vulnerable population, list of program shortcomings, list of a few recommendations for health reforms. So, what is the family planning? Family planning refers to conscious effort by individuals or couples to regulate the number and spacing of their children through the use of contraception or other method. Objective of family planning is to promote maternal and child health, to reduce unintended pregnancies, to empower individuals and couples to make informed choices, to enhance economic and social development. Benefits of family planning are to improve maternal and child health, to reduce maternal and infant mortality, to enhance educational opportunity for children, and economic benefit for families and communities. The role of family planning in achieving sustainable developmental goals. So it is beneficial for the goal number 3. Good health and well-being. Family planning contribute to improve maternal and child health, reduces maternal mortality, and prevents unintended pregnancies, promoting overall well-being. A sustainable developmental goal refers to quality of education. Family planning supports educational opportunities by enabling individuals to plan the timings and spacing of their children, allowing for better educational and career planning. Goal number 5 goes with gender equality. Family planning empower women to take choices about their Family planning empowers women to make choices about their reproductive health, education, and career, contributing to gender equality and women empowerment. Uh, Goal 1, no poverty, and Goal 8, decent work and economic growth. Family planning can contribute to poverty reduction by enabling families to have the number of children than they adequately support, leading to improved economic condition and opportunities for individuals. Uh, Goal 2, zero hunger. Family planning can help addressing population growth, reducing pressure on resources, and contributing to sustainable agriculture practices. Goal 6 goes with clean water and sanitation control. Population growth through family planning can alleviate the strains on water resources and contribute to sustainable water management. Goal 13 goes with climate action, take urgent action to combat climate change and its impact. Family planning can be seen as means of responsible population management, contributing to efforts to mitigate the impact of population growth on climate change and environmental sustainability. Goal 16 goes with peace, justice, and strong institution. Addressing population issues through family planning contribute to social stability, reducing the potential for conflicts related to resource scarcity and demographic pressure. So, what is a family planning program? Family planning programs are public health initiative or interventions designed to promote and support the voluntarily regulation of fertility within a family. These programs aims to provide individuals and couples with information, education, counseling, and access to a variety of contraceptive methods. The primary goal is to enable people to make informed decision about the number and spacing of their children, ultimately contributing to improved maternal and child health, reduced maternal and infant mortality, and enhanced overall well-being. So here's some background. This graph shows the population fertility rate of different countries like India, Pakistan, Bangladesh, we can see that in 1950 the fertility rate for Pakistan was 6.8, which reduced to uh, 4 point something in 2010. Fertility decline at the inception of population program. Pakistan fertility decline rate 6.6 births woman was between India's 5.9 and Iran's 7, but experienced fertility decline the slowest in the region. 1990s Pakistan total fertility rate as one birth more than India and Bangladesh, and two births more than Iran's. Within current total fertility rate, Pakistan is set to reach the proposed 2020 goals in 10 years. Contraceptive prevalence rate in Pakistan remained relatively below 10% during the 70s, but increased significantly by 1990s to almost 28%. Contraceptive prevalence rate increased from 21% to 49%. Use of contraceptives in rural areas has increased over the past 2 decades, still lags behind significantly. Fertility regulation, the contraceptive prevalence rate is 30% in Pakistan, a figure that has virtually remained the same over the last decade, which is considerably low as compared to other Muslim countries. Iran has 74% contraceptive prevalence rate. Bangladesh has 56%. Here are the methods used in Pakistan in females of reproductive age, where we can see 2.3% females use IUDs for contraception, 2.3 use injectables, 6.8 use condoms, 7.9 use traditional methods, and 8.2 females use the sterilization, while 70.4% females use no method of contraception. Here we can compare the changes and frequency of use of contraceptive method with passage of time, which isn't have much difference. Induced abortion being illegal still prevail with an estimate figure of 8,90,000 in 2002. On a rough scale, average 29% of 29 of 1,000 pregnancies end up with induced abortion. This trend is heavily exercised by women bearing more than 3 children. Here are the unmet needs in 1991. 40% women wanted to limit childbearing. In 2007, it is increased up to 52%. Although more than 50% of women wish to limit childbearing and around 20% wish to space their next birth, only 30% are using contraception, indicating unmet needs. The proportion of recent births that are unplanned rose from 21% in 1991 to 24% in 2007, which leads to potentially unsafe abortion. Unfortunately, Pakistan is one of them countries in which were declared by London Smith will be the largest family planning event, where 69 poorest countries with highest unmet need of family planning will participate. Out of those women who opt against contraception, 28% choose to do so by leaving it to God. This reason is closely followed by opposition from husbands, fear of side effects, the lack of knowledge, and 5% have perceived religious prohibition. Vulnerable group, the poor. Fertility rate in Pakistan vary by women, education, and household wealth status. Women across all wealth circle desire for lesser childbearing in 2007 and 1991, but richer women use contraceptives much more to prevent such cases. This gap of contraception uses has raised alarmingly between women of different wealth status over the past decade. Unmet need during 1991 stood better for poor women, but lack of contraceptive usage in comparison of desire to limit childbearing take it to 30%, while unmet needs of richer women are practically non-existent. Lack of awareness, lack of access. Access to family planning services in Pakistan varies from urban to rural. It takes 40 minutes on average to reach a rural health facility in urban areas, while it takes 96 minutes to rural areas. Distressing, the amount of poor population in rural areas is far higher, causing lack of contraceptive usage and superfluous childbearing. Quality of family planning services remain a huge block in path of applying population policies. It is found that over time, increasing number of women have reported fear of side effects and health concern as their primary reasons for not intended to use contraception in future, both in urban and rural areas. National Program for Family Planning and Primary Health Care, also known as Lady Health Worker Program, was launched in 1994 by Government of Pakistan. The Lady Health Worker model employment of over 1 lakh lady health workers, recruitment and training, first level of care facility. Scope of work was one lady health worker was equivalent to 100% in 150 homes. Supervision and monitoring, lady health supervisors and field program officers. For third party evaluation, lady health workers play a substantial role in preventing and promotive care and in delivering some of their basic curative care in their communities, as well as providing a link to emergency and referral care. It also concludes that lady health worker program has significant impact on population itself, and it has maintained the impact despite significant expansion of program. Current situation, contraceptive requirement, uh, Directorate or Material and Equipment expected to increase from reported 8.4 million in 2009 to 10.8 million in 2015, dependent on international funds. Local manufacturing of pills and injectables is already underway, and feasibility studies are under consideration for establishing IUD copper T manufacturing units in Pakistan. Funding funds were primarily produced by federal government and then distributed to provinces, shifted in international fund from family planning to rural health in 1990s and to HIV AIDS recent has damaged the progress of family planning program. Major funding is provided by KFW and UNFPA and UNSED. Bulk of these funds are used in social marketing, acquiring contraceptives. Public-private relationships, social marketing, NGOs and CBOs, public-private sectors, organizations, target group institutions. Current socio-economic factors, economic growth, but low education, increase economic growth, decrease progress in social sector, neglect education, plus social growth, 44% employment from agriculture, low focus on educational aids to youth, family planning services, past 2 decades, increased primary education, low secondary education, literacy rate 53%, poorest and lowest rate. Current socioeconomic factors are low participation of women in society, male dominated society impedes women to use family planning services. Rural Health and Family Planning Survey 2003, 1 in 3 women was not allowed to leave their home alone, and 42% of women who were able to go the health center on their own were using contraception compared to half that proportion, 21% who were not allowed to go to these facilities at all. Pakistan has the highest gender gap in labor force, women employment 19% from 13%. Program initiative population policy 2002 was strong in principle but fails in application. No proper planning before starting new program. Instead of introducing new programs and addressing latest issue, only old plans were reinforced. Expansion of family planning services remained restricted to urban areas. Used to contraceptives remained confined to urban areas through organizations and ASCII and Green Star social marketing. Lack of understanding of population issues. Other public official hesitate from even discussing is due to the religious pressure. Provinces often support population growth to get 100 with government awards and aids. Family planning in Pakistan still has a long way to go. Recommendation: without making educational accessible to all corner of society, particularly women, as contraception prevalence rate of global standards can't be achieved in the long run. Women education can lead to Pakistan transformation from agrarian society to an industrialized space where gender roles, abilities, and power will be worked more imperatively, leading to better implementation of family planning policies and rural health services. Role of stakeholder: the economic and finance partners, including the Ministry of Finance, who need to understand the economic growth is directly proportional to better family planning services. The health partners, improving family planning and rural health services by working together and putting organizational effort would further help private and public providers. International community and donors need to emphasize on family planning services along with other medical aids, as it can help reducing those medical issues in future. Furthermore, they must use the opportunity to help Pakistan when it eagerly wants to improve its family planning record. Ownership of family planning program, governance, service delivery, coordination, access and equity, strong monitoring and oversight role at the center, but full participation of provinces. Here, the model for family planning: use of family planning, knowledge and interest, quality and access. Social and political environment will be favorable. Here are the contraceptive devices which can be used. In conclusion, components of family planning program uh, are to assess a variety of contraceptive method, education and awareness program, healthcare infrastructure for reproductive health services and counseling and support services. Challenges faced in family planning are cultural and religious beliefs, lack of awareness and education, accessibility to services, stigma, and misconception. How we can overcome the challenges: community engagement and awareness campaigns, integration of family planning into primary healthcare, collaboration with religious and community leaders, ensuring affordability and accessibility to contraceptive method. Future action for the family planning programs are emerging technologies in family planning, addressing the needs of diverse population, strengthening the partnership and collaboration. Recent advances. Here, a study with the title of Population, Fertility and Family Planning in Pakistan, a program stagnation is included. In this study, we can see the first demographic pyramid, which shows in axis level the uh, population growth, and on y-axis we can see the age group distribution. In second graph, we can see the total fertility rates in selected South Asian countries in era of 1965 to 2005. Here we can see Pakistan showing the orange line graph, which was around 6.8 in 1965 and declined to uh, 4.6 in 2005. Other countries like Bangladesh also were having the same value in 1965, but it has declined to 3.8, and showed the more progress in Pakistan. Here we can see in figure 3 the total fertility rate in x-axis and period of survey coverage in on y-axis. which is being improved with passage of time. In figure 5, we can see the contraceptive use and their percentages among reproductive age, and it has been discussed previously. 70.4% females are not using any sort of contraceptive method. Figure 6 show the donors voted for population of Pakistan in 1996 to 2005. Here we can see the assistance with yellow line, reproductive health with gray dotted area, and family planning with green dotted area. We can see the coherence of assistance and family planning at this graph. The future family planning in Pakistan, the expert demographer and family planning program, Roth and colleagues have found that countries in which contraceptive prevalence reaches a plateau generally takes a step to address the stall family planning uses, and that plateau rarely repeat in country. Still, some factors bode well for the future of Pakistan family planning program. There is a clear latent demand for family planning, with 70% of married women using the contraceptive method and 25% indicating an unmet need for family planning. Long-term method, which by nature have lowered discontinuation rates, are popular. Further, Pakistan low HIV prevalence means fewer stressing or reproductive health budget and less competition for funding. Although young age structure can exacerbate challenges to development, and these profiles are not static, Pakistan government should also take heed of proven and cost-effective family planning and reproductive health policies that can promote greater demographic balance. Now, time for MCQs. In a region with limited access to healthcare, which family planning method would be most suitable for rural communities? A. Birth control pills. B. Injectable contraceptives. C. Condoms. D. Sterilization. E. Intrauterine devices.
IUDs,
Anyone? Answer is
intrauterine
B.
device.
Injectable contraceptives. MCQ number 2, a couple is concerned about delaying childbearing due to wife's career aspiration. Which family planning method provide a reversible option for postponing pregnancy? A. Sterilization. B. Implants. C. Intrauterine devices. D. Condoms. A. Emerging contraception. Answer is B.
C.
Implants. MCQ number 3, a woman experiences side effects with hormonal contraceptive with non-hormonal family planning method would be a sustainable alternative. A. Birth control pills. B. Injectable contraceptives. C. Intrauterine devices. D. Implants. E. Condoms. So answer is
Implant.
C. Intrauterine devices. MCQ number 4, in a community with cultural and religious beliefs opposing modern contraceptive method, which approach could be effective in promoting family planning? A. Community-based education and awareness programs. B. Imposing legal restriction on family size. C. Providing free sterilization services. D. Introducing mandatory contraception use. E. Limiting access to family planning services.
A.
Answer is A. Community-based education and awareness program. MCQ number 5, government is implementing a family planning program to address overpopulation concern, which strategy would align with substantial developmental goal, a sustainable developmental goal. A. Encouraging large family size. B. Implementing comprehensive sexuality education. C. Restricting access to family planning services. D. Promoting early marriages. D. Providing free contraception. So the answer is B. Implementing comprehensive sexuality education. MCQ number 6, in a country with a
महानूर
high
आप अपनी प्लीज
maternal
रिकॉर्डिंग
mortality
ऑन करें.
rate, which family planning method would be most effective in reducing maternal death during childbirth?
Mahnoor, आपके रिकॉर्ड
Condoms, B. Birth control pills, C. Emerging contraception, D. Intrauterine device, E. Sterilization. So the answer is D. Intrauterine devices. MCQ number 7, a couple desires a family planning method that does not require daily attention and provide long-term protection. What method would you recommend? A. Birth control pills, C. Condoms, C. Injectable contraceptive, D. Implant, E. Sterilization. So the answer is D. Implant. MCQ number 8, in a region with high teenage pregnancy rate, which family planning approach would be most effective in reducing unintended pregnancies among adolescents? A. Sterilization, B. Long-active reversible contraceptives, C. Emerging contraception, D. Condoms, E. Birth control pills. The answer is B. Long-active reversible contraceptive. MCQ number 9, a government is committed to achieving gender equality through family planning initiative. What aspects should be priority in their program? A. Promoting only female-focused contraceptive method. B. Ensuring men's involvement in family planning decision. C. Limiting access to family planning services for women. D. Implementing mandatory sterilization for women. E. Providing free contraception. So the answer is B. Ensuring men's involvement in family planning decision. MCQ number 10, our government is considering strategies to integrate family planning services into existing healthcare infrastructure. What is a key benefit of this approach? A. Increased cost of family planning services. B. Limited access to contraceptive methods. C. Improved overall reproductive health outcomes. D. High rates of unintended pregnancies. E. A decrease in number of healthcare facilities. The answer is C. Improved overall reproductive health outcomes. Here's the key. It is the YouTube channel where presentations are uploaded. Kindly like and subscribe. Thank you.